Hello and welcome to another episode of The Power of Story and Science. I'm your host, David Otey, and on this program we have a mix of content and conversations on the subject of how we can live out our work in science and engineering and technology, and even, as you're going to hear today, in medicine by telling the story of that work. I'm very excited to have as my guest today Dr. Robert Dickson. He's joining us from down in Texas, and I'll just say, how about a quick hello, Rob?
Hey, thanks very much for having me on, David. I really appreciate it.
You're going to hear a good bit more from Dr. Dickson in just a moment. First, let me kind of give you his credentials as well as a little bit of true confessions here, a little bit of a waiver. Dr. Dickson is the medical director for the Montgomery County Hospital District EMS. Montgomery County encompasses the northern suburbs of Houston, so it's just north of Harris County, which you may be familiar with. That's where Houston is located. So he's the medical director for an ambulance system that serves the northern Houston suburbs. He is also assistant professor. Sometimes the mouth just doesn't work. Assistant professor of emergency medicine at Baylor College of Medicine in Houston. And also, in the interest of full transparency, you should know Dr. Dickson, or Rob as I call him because I've known him for many years, is my brother-in-law. And I'm so thrilled to have you on the show today, Rob. I'm just going to call you that. Our viewers can call you Dr. Dickson.
No, that's fine. That's fine. Thanks. No, it's a pleasure to be here. It's a pleasure to be on the podcast and speaking with you today.
And you have a podcast of your own, which you'll tell us about a little bit later on, but I just wanted to make note of that right now so we plant that hook in people's minds. Rob, I know that you practice emergency medicine, which covers a whole gamut of things. And yet I also know that you've published and done a lot of work in the area of strokes and stroke care. And I wonder if you could tell us a little bit about that and how that became so important to you.
Sure. I think, as we had talked about before, I think you always have to start with the why and then the how. I'll give a little background about our service and kind of how I got here in Montgomery County. I trained as an emergency physician and worked in private practice and academics, kind of quasi-public private academics in this country and in New Zealand for about 15 years. And then I was lucky enough to come back and take this position with the Baylor College of Medicine in Montgomery County, providing EMS medical direction for our service. We have a very large service area. It's about the size of Rhode Island up here in North Houston, serviced by about 35-ish trucks or ALS vehicles with transport vehicles with paramedics, dual paramedics, supported by about 1,000 firefighters in 12 different fire departments. So really, really large area. And we answer about 70,000 calls for service a year. And
Wow.
Stroke is one of those emergencies that we respond to. This has a kind of a special meaning to me. My mother suffered from a terrible, terrible stroke. I was graduating from residency, from medical residency back in the early 2000s. My mother had just been to Indianapolis for a big party. She was well. She was a healthy woman, worked out. She was actually at the gym when she collapsed, was noted to have acute symptoms of stroke. So she had difficulty speaking. She could not move her one of her sides. I can't recall which side stroke it was, but a pretty devastating stroke. She got excellent care. Immediately someone tended to her. They called EMS. They immediately diagnosed her stroke. They took her to an appropriate stroke center, and she got the best treatment she could at the time, which is a reperfusion drug, a drug called TPA that we use as a clot busting drug to try to reperfuse the brain and open up those blood vessels that are blocked going to the brain. Sadly, she did not recover from that. The therapy, the type of stroke she had was what's called a large artery occlusion, which is a big clot in a big vessel that's going to the brain. And so sadly, our treatment of choice, the best treatment we had, even though she got the best care she could possibly get, that we knew in medical practice. She succumbed to her brain injury from her stroke about 18 months, 2 years later. And that's really what got my interest in stroke. I had always been, in my academic career, had been interested in doing work in systems of care, how we diagnose transition care, how we look after patients in EMS from the 911 system all the way to the emergency department and to either to the angio suite for a stroke or the cath lab for a cardiac procedure, or maybe a major trauma or an out-of-hospital cardiac arrest, the ICU. How do all those silos of medical care fit together? And right before I got this job here in Montgomery County, I was a consultant. I was a emergency medicine consultant at a teaching hospital in New Zealand. And I was in an office afternoon. It was about 4 or 5 in the afternoon in New Zealand. And this email came across my email stream. And it was a publication of two landmark papers in stroke. And it was essentially retrieving strokes using mechanical embolectomy. And that's where just like in cardiac caths, we run a catheter up through the groin, through the artery, and essentially retrieve the clot right out of the brain. Now, this therapy had been tried for a number of years. And in 2015, the first landmark trials were published. And they were published open access, which means everybody on the planet can read them. So super important. The same day they were presented at the big international stroke conference. So it's just unheard of. And these two publications were in the most prestigious journal, I think, the New England Journal. And so I started reading these. And about 7 o'clock, my wife called me and said, "Where are you? You coming home for dinner?" And I was just transfixed on this. Now, here is this therapy that at the time, had we had the technology perfected, and it's really a combination. This has been trial and error in medicine for years. We did it in heart attacks. We know how to open up vessels in heart attacks, but it is a combination of technology, the device, the operators, the clinical operators, so our neurosurgeons, our surgeons that are doing, and the neuroradiologists, and the folks that are doing this procedure, and it's the techniques. So it's equipment, training, techniques that really all came together in these two landmark trials. And what those trials showed is that essentially for every person who has one of these devastating, horrible strokes, like my mom did, if you treat those people with endovascular clot retrieval, if they have, in fact, a large artery occlusion, 1 in 3 of them are essentially going to be disease-free. They're going to walk out of the hospital with all their faculties, with very little disability. So most of those people, really, it's the most robust therapy that we've had for stroke in my entire career, which to me, it was just this aha moment of, oh my gosh, this is one of the most powerful therapies that's come.
That's amazing.
In transition to when I got here at MCHD, that technique, that nomenclature of large artery occlusion was brand new. And so what we started working on here, my team in the clinical department, and our entire clinical team, was developing protocols and guidelines and training on how paramedics, how phone operators, the 911 system, paramedics diagnose these strokes and get them to the right center. Because this endovascular clot retrieval, especially at the time in 2015, 2016, was not widespread. When I came here, we had one center of our 6 major hospitals in Montgomery County that could do this procedure. I now have 4, and I'm getting ready to have 5 of the 6.
So it is being adopted more widely then.
Vastly adopted. And we work very hard, our team here, in conjunction with all of our partner system hospitals here in the northern Houston region to develop these protocols and communication and feedback with the stroke teams. So we made sure we got the right patient to the right hospital in the right amount of time.
That's quite the story, Rob. again, for those who may have missed the beginning, Rob is my brother-in-law, and his mother, whom I remember fondly, was my mother-in-law. And I remember the day, it was Father's Day, wasn't it?
I believe it was.
Yeah. And my wife got a call. It may have been from you, I don't know, or another family member, about that stroke that she'd had. And then I learned later that she was in the right place. I mean, people recognized right away that she'd had a stroke, and that doesn't always happen. And then she had prompt EMS response, and that sadly doesn't always happen depending on where someone's located. And then was treated, as you say, with the best clot-busting drug that was available then. I mean, she got everything she could have gotten to go right at that time, but it just didn't go right for her. And if there had been that technology available to just go in and remove the clot, that's just amazing to me that can be done now, then her outcome could have been quite different, because I know it really affected the quality of her life for the last couple of years of her life.
Very much so. And I think, I lecture really around the country on this topic. And I always start this lecture with asking the audience, how many people in any given audience, and I'll ask your audience, have had a loved one, a family member, someone in your own family suffer from this terrible disease of cerebrovascular disease or stroke. And it's not a small number. It's a very prevalent disease in this country. 700,000 strokes in this country a year, and about 30 to 40% are going to be this type of large artery occlusion, which is a very disabling stroke. It makes sense that a large clot in a large conducting artery to the brain that feeds the brain with blood would give you terrible neurologic symptoms.
Sure, because so many functional areas of the brain were affected. I mean, I know she had motoric impairment, she had language impairment. Because of the language impairment, it was hard to tell how much cognitive impairment she may have had, but she was severely impaired.
Correct. This is a terrible disease. And I think the most important, fact of all the kind of stroke factoids is how prevalent it is and how common these large artery occlusions are, and what hope we have in this relatively new therapy for medicine. It's been around really since 2014-15, but now it's really coming to favor for the treatment of these large artery occlusion strokes. And it's very, very effective. Probably, I would say, the most effective medical therapy that I have come across, the most important in my medical career.
Wow, that's really amazing. And what I loved about what I heard just now was it wasn't just about the technology, but the story. Because so many people in the audiences you speak to, so many people I'm sure in my audience will have stories of people who are affected by stroke. And to go from a sense that stroke has always been scary because it's so unpredictable. And because for so long there was so little hope for for stroke patients. And you've just given people a lot more hope. I had no idea it was, even with the conversations you and I have had, I had no idea until just now that it was possible to go in and actually remove a clot that was causing a large artery occlusion. Amazing.
Yeah, it's amazing therapy and some amazing systems of care, and kind of the kicker of it, and one of the really most important things that we've been working on is the time-sensitive nature of all these emergencies. If you can think about it, David, when you have a lack of blood flow to the brain, that tissue dies.
Yeah. And
brain tissue, guys, like other tissue in the body, doesn't regenerate. So when it's gone, and that deficit is there. And the older we are, we have less ability to compensate for those deficits. Mm-hmm. So it gets to be, particularly as we get older, our risk of stroke gets greater, along with other risk factors. Some we can control, some we can't, right? So we can control our blood pressure or hypertension, one of the big major causes of stroke. Tobacco use, cigarette smoking, we can control that, right? Our blood cholesterol, things like that. What we can't control is our genetics and how our blood clots and those type of things. So, I think that the technology has really come a long way, but particularly in this procedure, it is very important that the correct diagnosis be made, and it's very time sensitive, i.e., if the 911 system is not activated by a family member immediately. Upon, exactly, time is brain. And so the immediate activation of the 911 system, the early diagnosis, really by the telephone operators of a high probability of stroke, sets our process into motion here, where all of our fire crews, all of our paramedics that are responding to that residence understand that they are there to, number one, on the differential for that patient is a likely stroke, and to start going in that algorithm to evaluate, does it have the potential to be a large artery occlusion and need to go to a comprehensive or a thrombectomy capable stroke center. So lots of decisions. We had to develop new diagnostic tools here the paramedics use in the field, lots of new training around some of the things that we've been talking about. And then really getting the whole system in the same room to talk about this and do quality feedback of where can we improve this system to get the patient as quickly as we can from 911 response to the neurosurgeon and have that clot being removed on the table. And I'm very proud to tell you that in Montgomery County, our average time is between 60 and 90 minutes for that, which is extraordinary.
From the call to on the table?
From the time that we get the patient to the door of the ED. So you have to add a little bit of time for the call.
Transport time.
The door time to groin time, where they puncture the groin and start going after the clock, averages in all of our systems here, averages between 60 and 90 minutes.
And so you've had some success stories, I'm sure.
We had great success stories. You can Google them, and I'll put some links in here.
Okay, we'll put those in the program notes.
Right, the MCHD Paramedic Podcast that my partner here, Dr. Casey Patrick, and our clinical staff, he is the founder of this idea, and it's a medical education podcast that we use here primarily to train our first responders on medical topics like large artery occlusion stroke. But we've had some fantastic outcomes, and there's nothing, I think, better than to see how this technology, all the work that the systems and the different types of doctors and providers that care for folks that has gone into this, and see how that translates to real people that had a terrible deficit that are now back with their family, that, can go to work and can be a part of our community.
That's amazing. That truly is. It truly is. I'm so glad to learn more about that. And I'm glad you mentioned the podcast, and there will be links in the program notes accompanying this, whether you're getting this as a podcast on Podbean or any of our other platforms, or whether you're seeing this on YouTube. Check the program notes, and we'll have those links in there for you. Rob, I wonder if I could shift direction just a little bit.
Sure.
I've known you now for well over 30 years. You've been through some transitions in your life during that time, as have I. And one of the things that I find inspiring about you is the journey that you made from your first career into what you're doing now, because you gained some insights into what motivates you along the way. Would that be accurate to say?
Sure.
Yeah. Can you tell us a bit about that? Why don't you can pick it up wherever you like, but I was thinking maybe right after you left the Navy.
Sure. So I hate to tell on myself, David, but you've known me for a long time, and actually you did know me a lot before the Navy. But I was not a great student. I was not a big fan of high school and things like that. I was kind of an adventurer and wanted to get out and about. And my first career out of the Navy, and I kind of dropped in out of college, was law enforcement. I was a Dallas police officer for 8 years, and really enjoyed my work there. Tremendous work. And then after 8 years, I transitioned to the fire service. And the fire service there at the time, and now still, cross-trains as paramedics. So most paramedic services in this country, about 75% of them are fire-based. So I transitioned to the Dallas Fire Department. And I went to paramedic school. And then I guess we all have that moment in our academic life. I'd never been terribly interested in lots of the topics I was learning about. I loved my work. I enjoyed law enforcement. I enjoyed dealing with people. I enjoyed a job that changed every day and you had new challenges every day. And when I went to paramedic school, that just clicked for me. And I thought, I found what I need to be doing. And I took really a lot of those skills that I learned on the street as a police officer, as a paramedic, dealing with other human beings, dealing with crises, communicating with people. I mean, in everyone's work that listens to this podcast, all the folks that we know, and no matter what profession, those are skill sets that are invaluable, and they're certainly invaluable in medicine.
True.
If we can't communicate with our patients, we don't make very good doctors.
Well, that's true. I think there are a lot of people who would agree with that, based on perhaps unfortunate experiences, and fortunate ones as well. I mean, I can think of some doctors I've seen who have been excellent communicators, and I just think that makes such a difference at putting people at ease. But just to go back and drill down a little bit on your story, it was paramedic school that prompted you to finish your degree and then apply to med school, right?
Correct. Now, my first degree was actually in finance. Actually, it's a little bit backwards. I had finished it a couple of years before as in economics and finance, but I had
Okay.
no medical prereqs for med school and things like that. And I was an older student. I was married. I had children, and I kind of thought to myself, and I think many adult learners get there, right? Don't they? That gosh, I can't do this. I'm too old, or all the reasons that you can't do something.
Yeah.
I always hear doctors and other professionals, and I hear this all the time. It really it gets on my nerves, actually, when like a senior person will ask some junior in any profession, gosh, what do you want to be when you grow up? And I think that my answer to that is I've always tried to be what I want to be every day. And when I was a police officer, I loved being a police officer, and I loved the people I worked around, and still do. I still have relationships with them to this day. When I was in the fire service, I loved the work that we did there, and it all builds, life experiences, work experiences, relationships build on themselves. If I always tell folks, had I not done it the way that I did it for me, I don't think I'd been a very good doctor. I had to have that background for me to, I think, get to the place that I am now.
What a great lesson for all of us. You had to go through what you went through to get to where you are now. I mean, it sounds simplistic when you boil it down to that. And yet I think so many people wonder, what is my path? How do I know where it's going to take me? And I feel the same way you do. All the experiences that I've had in first my career in broadcast engineering, and then switching over into training and public speaking and coaching other speakers, and then starting this podcast last year, it's all brought me to where I am right now. Even the things that I've done as avocations, acting on stage, all of that comes into what I do as a speaker and a communicator, and I just think we have to acknowledge the value of that and revel in it. But I do want to state publicly for this audience right now, Rob, what an inspiration your story has been for me. That you went from, as my wife had told me, not being a really great student, but someone who had known since you were young that you wanted to be a cop. And then you did that, and then found something else, and it led you to where you are now. And I think we can certainly presume, I won't say assume, that you wouldn't be the emergency physician you are today without those experiences you had on the street, without the experiences as a cop, as a firefighter, as a paramedic. And I'll bet that you relate to that staff that you supervise in a unique way because of all that.
I hope so. I mean, our Dr. Patrick's and I's, main focus and main priority is to support our people that support the mission. And our mission here is to provide the best, absolute best care that we can for every one of our patients. When they call 911 and we answer the call, we want our people to go out there and do the absolute best with the absolute best equipment that we can provide them, and the best training and support from the medical directors to the benefit of the patients. Here we have a saying, it all goes back to the patients.
Yes, it does, doesn't it? All goes back to the patients. Well, Rob, it's been delightful to have this conversation with you. I've learned some things and had an opportunity to share some thoughts from my heart with you. And as just a quick wrap up here, and I know we're going to put this in the program notes, but tell us just a little bit about the podcast, what it's called, and where it can be found.
Sure. Thanks very much, David. I really appreciated speaking with you this afternoon. The podcast is an educational podcast. It was started here by my partner, Dr. Casey Patrick, and our clinical staff here at Montgomery County. It can be found on any of the places you consume your podcast. So we are on iTunes, SoundCloud, Spotify. You can contact us at the podcast email, or email me or Dr. Patrick on any of these topics we've talked about, or any one of our casts, at podcast@mchd-tx.org. And we'll put a link to that in the show notes.
And the title of the podcast is?
It's the MCHD Paramedic Podcast. Really catchy, cool title.
Really catchy, cool title.
It's actually, we bantered them around, but that was the coolest we could come. We're doctors, not like, we used this initially for an educate. We kind of fell into podcasting, but it wasn't what we set out to do. But it's been very successful. We think it's a great way to communicate with all of our providers across this great area. We have different levels of EMS providers, and to provide that baseline training. So we have the MCHD Paramedic Podcast, and we also have a video cast where if we have a topic like electrocardiography to diagnose heart attacks and things like that, something that needs a visual, called MCHD Paramedic Podcast 360. So you can check us out there at the MCHD YouTube channel. Has all that content on if we need to show a medical procedure, a diagnostic case series of cardiograms or something of that sort that needs a visual. We do the Podcast 360.
Wonderful, wonderful. It's been such a pleasure. Thank you for being on the show with me, Rob.
Yeah, thanks for having me.
I've been talking today with Dr. Robert Dickson, the Medical Director for Montgomery County Hospital District EMS in Texas, and Assistant Professor of Emergency Medicine at Baylor College of Medicine in Houston. And I'm David Otey on the Power of Story and Science. If you'd like to contact me or learn more about this program, the easiest place to go is simply storyandscience.com. That will take you to the home page of this program. And as always, thank you for being part of the Story and Science community.